Before we get started, just a quick word from World Extreme Medicine. If you work in pre-hospital, remote, expedition, humanitarian or high-risk environments, World Extreme Medicine exists for one reason: to help you deliver safe, effective care where resources are limited, decisions matter, and help is a long way off. From expedition and wilderness medicine to hostile environments, dive medicine, leadership, and human performance under pressure, World Extreme Medicine bring together clinicians and operators with real-world experience in some of the most challenging settings on the planet. Their courses, webinars, and global faculty are built around practical decision-making, not just theory, to focus really on what actually works when things go wrong, far from definitive care. To find out more and explore upcoming courses and indeed educational content, visit worldextrememedicine.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today I'm with a friend and colleague from a blog post and indeed a Substack website called High Adventure Healthcare. Laura Hall is one of the authors of the fantastic Substack blog, and we'll put links in the show notes to the fantastic educational and indeed inspirational blog post that she and her co-author Kelly write. So we've got Laura with us today to really unpack a number of blogs really. Today we're going to unpack one of the blogs really around acute mountain sickness. Before we do, welcome Laura to the podcast.
Yeah, thank you so much for having me. I'm excited to be here.
Yeah, it's fantastic just to walk through this and actually many other blog posts with you, actually. So today we do a bit of a deep dive into acute mountain sickness. It's a fantastic blog post, Laura, and we'll put links in the show notes so that people can go away and read it in slow time, because I think it's important just to do that. But could I get you to speak to why you wrote the piece initially?
Yeah, that's a great question. This piece actually started as a school project. I was asked to create an informational pamphlet that could be used at the facility that I worked at. And, I think a lot of my classmates were writing about, hypertension and diabetes and, these more traditional kind of disease processes that we learn about in school. And I decided, I work at this um, high standalone ski town ER. So it sits at about 8,750 feet. Sorry, I'm not sure off the top of my head what that is in meters. Um, but we see quite a bit of acute mountain sickness there, ranging from just your average altitude illness all the way up to high altitude pulmonary edema. And I just started to notice this pattern where we'd get a lot of tourists from low landing states, and they'd come up and they'd stay and play at these higher elevations, and they had absolutely no idea what the risks were for altitude, and also how simple it can be to intervene when you're in kind of that just mild acute mountain sickness. And so, yeah, it started as a school project, and then I was like, wait a minute, this would actually be a really interesting post for High Adventure Healthcare. So,
Yeah, indeed. No, indeed. And it's a fantastic piece, actually, where you will hear it in AI format shortly. But I think to your point, and the piece brings this out as well, is around some of the subtle signs. I think to your point, that, people can present and it's just not abundantly apparent to them that it is acute mountain sickness, just the vagaries of a headache or indeed diarrhea or dizziness, but and dehydration being also a co-founder of the presentation. But it's just really, like you said, I think the first step is articulating. It's like, look at how long have you been at this altitude? Are you familiar with working at, or indeed skiing at altitude? And then some of the fundamental treatment options for acute mountain sickness. Just before we hear the piece, Laura, have you had any post-blog reflections at all, or indeed feedback or thoughts on the piece, or has it become a prevailing theme in the winter season where you are?
hmm Yeah, absolutely. I think the biggest thing that I notice is we see a lot of the advice around traveling to altitude. People say, "Oh, just arrive 2 to 3 days before." That's actually the worst time for people to arrive to altitude. Your body has started that adaptation process, but it hasn't quite finished it. So I describe acute mountain sickness as, it's the worst hangover of your life. Which, of course, when people go on vacation or, holiday to these mountain towns, what's the first thing they do? They go to the bar and they drink, and that just adds insult to injury there. And so, yeah, it's been really fun. And like I said, developing that pamphlet, it actually is in use at my facility now, and just as an informational, educational piece. And it's been just been yeah, really fun to just kind of get that information out there and kind of try and debunk that, 2 to 3 day timeline. The best thing to do is actually to arrive the night before. I think about this too, not only in the winter, but also in the summer with people that are going to like ultra marathon races at high altitude. Again, people are told arrive 2 to 3 days before to adapt. When really it should be, no, you should actually, if you can't afford to take the time off of work to arrive 2 to 3 weeks before, you should actually be arriving like the night before your event. So your body hasn't quite started that adaptation process yet. And sure, you'll suffer a little bit, but you won't quite be in the throes of the worst parts of acute mountain sickness.
Yeah, indeed. No, indeed. We're just about to hear it in AI format. Laura, it's always a pleasure to catch up with you. Thank you.
Yeah, thank you so much.
Imagine the worst hangover of your life. I mean, the headache is just pounding, your stomach is churning, you feel dizzy, completely wiped out.
It's awful.
Now imagine feeling all of that, but you're standing on some beautiful mountain overlook. You're totally sober, miles from a pharmacy. It is just the worst feeling.
It truly is. And that feeling, that's the classic presentation of acute mountain sickness, or AMS. It's what happens when your body, well, it tries and fails to adapt to high elevation quickly enough.
And it's usually just miserable, but for a few unlucky people, it can progress from just a mild annoyance into something really life-threatening.
It can, and quickly.
Exactly. And we know a lot of you are getting ready for mountain trips, whether you're climbing a peak or, just visiting a high-altitude city, maybe a ski town.
So our mission today is to cut through all the noise. We want to arm you with the essential knowledge you need for prevention, for survival, and for recognition.
We'll dive into the core science, the best prevention strategies, and most importantly, the really clear-cut symptoms that signal that shift from, say, a bad vacation to a full-blown medical emergency.
Okay, so let's set the baseline right away. AMS is diagnosed when a person, someone from a lower elevation, gets up to 8,200 feet or higher and then gets ill.
And how quickly does that happen?
Usually within several hours, but it can take up to 3 days. And the statistics we pulled from the source material show this is not rare at all. AMS affects about 17% of travelers who go to these higher elevations.
17%. That is a massive number of people dealing with headaches, nausea, no appetite, dizziness. And the first question is always why?
Right.
Everyone says, oh, it's because there's less oxygen up here.
And that is the classic misconception. This is where the science gets really, really interesting, because technically that idea is just fundamentally wrong.
Okay, I'm hooked. Why is that wrong?
Because the concentration of oxygen, the actual percentage of gas that makes up the air we breathe, is always 21%.
Always.
Always. Whether you are at sea level, in our studio right now, or you're standing on the summit of Mount Everest, the percentage of oxygen in the air does not change.
So if the concentration is the same, what is the real problem here?
The problem is the availability of that oxygen. As we go up in elevation, the atmospheric pressure decreases a lot.
Okay.
Think of it like this. At sea level, there's this heavy column of air pushing down. And that pressure helps shove oxygen molecules across the membranes in your lungs and right into your bloodstream.
But as you climb, that column of air gets lighter, so there's less push.
Precisely. It's not that the oxygen molecules aren't there. They just aren't being forced into your system with the same pressure. That lack of pressure, it's often called low partial pressure, means fewer oxygen molecules can successfully move from those tiny air sacs in your lungs, the alveoli, to the capillaries around them. And that physical difficulty is the root cause of every single symptom of altitude illness.
So your body immediately starts trying to compensate. It's working overtime. What are the first moves it makes in this physiological chess match?
The first, most immediate response is hyperventilation. You just start breathing faster and deeper.
Trying to bring more air in.
Exactly. You're trying to maximize the sheer number of oxygen molecules you bring in with every breath, just hoping more of them will make that jump into the bloodstream.
That makes perfect sense. More air in, more molecules absorbed. But I know this is where it gets complicated because that increased breathing, it messes with your blood chemistry, right?
It does, and this is where the deep dive really begins. When you hyperventilate, when you breathe off more than normal, you are blowing off carbon dioxide.
And CO2 is acidic in the blood.
It's dissolved as an acid, yes. So when you lose too much CO2, your blood pH shifts, it becomes more alkaline. And your body absolutely cannot tolerate that. So it triggers this massive chemical balancing act.
And that's where the kidneys come in.
They kick into overdrive. To correct that alkaline shift from all the rapid breathing, the kidneys start excreting bicarbonate.
The buffer.
It's the primary buffer the body uses to neutralize acid. By flushing it out, the body reacidifies the blood just to maintain that perfect acid-base balance. Over weeks, the body also starts making more red blood cells, but that immediate response is all about the lungs and kidneys.
That whole process is just astounding, but it takes months, right? For full, stable acclimation. And most of us, we only have a week for our trip.
Right.
So let's unpack this. What are the short-term, proactive steps we can take beyond just drink more water to keep from getting sick?
The single most important factor is your rate of ascent. Gradual ascent is absolutely the best medicine we have.
Okay.
And the source material, especially from the Wilderness Medical Society, really stresses the importance of controlling your sleeping altitude.
That distinction is key. Why is sleeping altitude more important than, say, the highest point you reach during the day?
Because when you sleep, your respiratory drive naturally goes down. That makes the hypoxemia, the low blood oxygen, even worse.
So you're more vulnerable.
Much more. If you ascend 5,000 feet in one day and try to sleep there, you're forcing your body to compensate when it's at its weakest. This is why you always hear climbers talk about the hike high, sleep low strategy.
They expose themselves to the stress during the day.
And then they come back down several thousand feet to sleep, letting the body manage that stress in a less severe environment overnight.
That makes perfect sense for mountaineers. What about just, lifestyle choices for the average traveler?
Well, obviously, good hydration, proper nutrition, those are essential. Avoiding alcohol and other depressants, like some sleeping pills, is critical.
Because they slow your breathing down even more.
Exactly. They suppress your respiratory drive, especially at night. And then there's that surprising dietary fact we touched on earlier.
The carbohydrates, I want to get into that. Why do we burn more carbs at altitude?
Well, your body is functioning in a state of hypoxia low oxygen. And when oxygen is scarce, the metabolic pathways that use fat for fuel, they just become less efficient.
So the body switches gears.
It does. It starts relying more heavily on glucose, on carbohydrates, because that metabolic process needs less oxygen to produce the same amount of energy. So you're just burning through your carbs faster, and you need to keep those stores full.
So eat the pasta, eat the bread.
Eat the pasta. Skip the low-carb diet on your mountain trip.
I feel scientifically validated in my snack choices now.
Okay, let's talk about pharmacological prevention. We have some serious tools recommended by the Wilderness Medical Society, the WMS.
We do, and the primary drug that WMS recommends is acetazolamide.
Which is a diuretic, right?
It's often categorized that way, but its real benefit here is that it acts as a respiratory stimulant. It chemically forces you to breathe faster, which rapidly increases your oxidation and, it just accelerates the whole acclimatization process.
So it's actually helping your body do the job it needs to do anyway. It is. And crucially, it addresses one of the most debilitating symptoms of altitude, that central sleep apnea, or periodic breathing.
Where you wake up gasping for air.
Yes. Acetazolamide gets rid of that, which leads to far more restful sleep, and that dramatically helps with recovery. A very important note, though. Anyone with a sulfa allergy has to avoid this drug.
So what's the alternative if acetazolamide is off the table?
That would be dexamethasone, which is a powerful steroid.
Yeah.
It's very effective at preventing AMS symptoms, but, and this is a key distinction for you to know, dexamethasone does not help you acclimatize.
So it just masks the problem.
It reduces the brain swelling and inflammation that cause the symptoms, essentially hiding the problem until your body can catch up on its own if it catches up. It's a great alternative, but it's really reserved for people with high-risk exposure or those with sulfa allergies.
So acetazolamide is the active helper, and dexamethasone is the powerful symptom masker. Is there a simple over-the-counter option that actually works?
There is. Ibuprofen, yes. Because it's an inexpensive, readily available anti-inflammatory, It's included in the WMS recommendations as a second-line option for preventing AMS. Studies have shown it has a real positive benefit, probably by reducing that initial inflammation that causes the signature headache.
That's a great toolkit for prevention, but we have to talk about the progression. While AMS is miserable, for the unlucky few, it can rapidly progress into two severe, life-threatening ailments: high altitude cerebral edema, HACE, and high altitude pulmonary edema, HAPE.
Right.
Let's get into the symptoms that demand immediate action.
We can almost think of AMS, the headache and nausea, as symptoms of mild HACE. It's an indication of some minor localized brain swelling from leaky capillaries reacting to the low oxygen.
Okay.
Severe HACE is the progression of that swelling, and it develops fast, often within just 12 to 24 hours.
So what are the terrifying warning signs we need to look for?
Severe HAE is a medical emergency. It demands rapid descent. You have to recognize the symptoms that show global neurological dysfunction. We use a memorable, if slightly crude mnemonic. HACE patients become a DICK head.
Okay, what does that stand for?
They are disoriented, irritable, and confused. The other hallmark symptom is ataxia.
Ataxia, that's the gait issue, right? The walking?
Exactly. They walk like they're drunk. The memorable cue there is if you're walking like you need a ride, you need to call a taxi.
Got it.
But a crucial caveat for any rescuer or clinician: these symptoms are identical to a severe traumatic brain injury. You have to rule out trauma, especially if you're dealing with a climber who might have fallen, before you jump to a HACE diagnosis.
That is a critical piece of diagnostic advice. Now let's move to the lungs. HAE, high altitude pulmonary edema.
HAPE results from changes in the lung circulation that force fluid to leak from the capillaries into the air sacs. You're essentially drowning from the inside. And it can take a few days to develop, which makes it really insidious.
And at first it just feels like a bad cold or something.
Initially, yes, it mimics a bad cold. Shortness of breath, but only with exertion. Maybe a dry cough or a mild fever.
So what's the line that separates a common cough from a life-threatening pulmonary issue?
The line is very clear. Shortness of breath at rest. If you are sitting down doing nothing and you are struggling to catch your breath, that is HABE until proven otherwise.
And then it gets worse from there.
It does. As it progresses, you might hear audible crackles in the chest, even without a stethoscope. They might start coughing up pink, bloody sputum, and eventually you'll see cyanosis, that blue coloring of the lips and skin.
You mentioned an anecdotal profile from the source material that really highlighted who gets this and why they often wait too long to get help.
Yeah, the data shows a pretty specific pattern. It often affects otherwise very healthy men in their 40s, usually traveling from very low-lying states, Texas, Florida, Arkansas, and they just ascend too quickly.
And they're stubborn.
They're often perceived as stubborn or stoic. Yeah. They delay seeking help until they notice a genuine gurgle in their chest. Or worse, they're found unconscious by someone else.
And that delay is just lethal. What kind of oxygen levels were these patients showing up with?
It's just shocking numbers. We're talking about oxygen saturations in the low 80s all the way down to the mid-30s.
Mid-30s, that's...
To put that in perspective, anything below 90% is worrying. The mid-30s is incompatible with life for any sustained period. This rapid progression is what makes HAPE so terrifying.
Mid-30s saturation, I mean, the brain and vital organs are just starting for oxygen. What's the immediate treatment?
The treatment has to be aggressive. High flow or positive pressure oxygen. Specific medications like nifedipine that affect lung blood pressure. And above all else, immediate rapid descent.
And there's a long-term consequence, too.
A huge one. And you need to know this. Once someone has experienced AP, their propensity to get it again is significantly higher. Prevention and vigilance become lifelong priorities for them.
That just makes recognition even more critical. Now, this brings us to the final fascinating section of our deep dive. There's a famous principle in wilderness medicine that guides diagnosis, but a true case study shows why relying only on that principle can be fatal.
The principle is absolutely critical, but you have to remember the whole thing. It's when at altitude, all illness is related to altitude until proven otherwise.
Until proven otherwise.
That's the key part. The altitude environment creates such a strong diagnostic bias that clinicians can get tunnel vision. But that proven otherwise clause is what saves lives, as we saw in a famous case study on Mount Aconcagua.
Tell us the scenario. Aconcagua is high. It's over 22,000 feet.
This incident happened at a medical tent at 14,100 feet. A 50-year-old man presents with classic HAPE symptoms: lightheaded, severe shortness of breath, crackles in his lungs, and dangerously low oxygen down in the 60s.
I mean, that's a textbook case of altitude illness.
Textbook. By the book, everything screamed HAPE. But the clinician on site made a decision that was outside the standard protocol. They used a handheld ultrasound.
Okay.
They confirmed the signs of HAPE, specifically bilateral pulmonary B-lines, that's fluid in the lungs. But the ultrasound also revealed a key finding in the patient's heart, a septal wall motion abnormality.
Which immediately means you can't just think lungs and altitude anymore.
Exactly. That one finding just blew the differential diagnosis wide open. Now, they were concerned about cardiac ischemia, a full-blown heart attack, potentially masked by all the altitude sickness symptoms.
And the treatment changed completely, I assume?
Fundamentally, they immediately treated him for a heart attack aspirin and a blood thinner, clopidogrel. Instead of giving him oxygen and sending him down, they flew him down immediately.
And what was the final diagnosis?
Hospital tests confirmed a STEMI, a very serious type of heart attack. He was stented, and he recovered fully.
So what does this all mean? The standard of care for altitude oxygen and descent. It would have helped his oxygen levels, sure, but it would not have addressed the underlying heart attack that was actively killing him.
It's a perfect example of the danger of diagnostic tunnel vision. I mean, kudos to that clinician for having the foresight and the technology to prove otherwise before just treating the obvious. The symptoms of altitude illness can mimic everything from pneumonia to a stroke. We have to use every tool we have.
Incredible. Okay, to wrap up this essential deep dive, let's recap the core takeaways you should carry with you on your next high-altitude trip. Remember the core science. The problem isn't the oxygen concentration, it's the lack of atmospheric pressure making that oxygen unavailable to your body.
And remember the prevention strategies. Go up gradually, sleep low, and recognize that your body is burning more carbohydrates when oxygen is scarce. Know about the active acclimatizing drug, acetazolamide, and the symptom-masking steroid, dexamethasone.
And finally, never ignore the progression. While AMS is miserable, you have to know the severe signs of ACE, that dangerous disorientation, and ataxia and HAPE, which is signaled by shortness of breath at rest and that worsening cough.
And this knowledge is vital for everyone, not just climbers. If you are traveling to any popular destination at 8,200 feet or higher, you need this information. It could literally save your life or the life of someone you're traveling with.
As we discussed, the human body's capacity to compensate is truly astounding. We talked about how just the simple act of increasing your breathing at altitude triggers this massive cascade, forcing your kidneys to excrete bicarbonate just to maintain that acid-base balance and keep you functioning.
That metabolic dance is happening constantly, often totally outside of our awareness. So consider this provocative thought. If a change in atmospheric pressure can trigger such a massive, interconnected chemical balancing act involving our lungs, our kidneys, our blood chemistry, all just to survive, what other subtle, massive physiological changes are happening inside us right now, triggered by environmental factors we rarely ever stop to consider?
The deep interconnectedness of the human body and atmospheric physics is truly something else. Thank you for joining us for this deep dive. Go explore safely.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.